Welcome to Finding Avalon, the podcast that amplifies disabled voices. I'm your host, Jenna, a disability inclusion advocate, communicator, and storyteller. This is a place where disabled folks correct the narrative by sharing authentic lived experiences. Join me as we explore life with disability through our lens, because representation matters. Welcome to episode 3 of the Finding Avalon podcast. Here we promote and prioritize authentic disabled representation, one story at a time. On this episode, we've got a special guest joining us from Mexico City, Fernand Vedrenne. Fernand is a healthcare professional and a clinician with ADHD who is driven by a passion for helping patients. His perspective of disability includes being a queer neurodivergent man who has experienced and witnessed disability discrimination. Fernand is concerned about weight stigma and fatphobia, as well as ableism around mental health. He was born and raised in Mexico City and has also lived in Europe and Canada. He first studied to become a dietitian and currently works in oncology, while at the same time he's completing his final year in medical school. With his dedication to patient care and advocacy, Fernand envisions himself working as a doctor in psychiatry after he graduates. Welcome, Fernand.
Hi, thanks for having me here. I'm very excited about talking and discussing different perspectives today.
I'm so keen to hear your perspectives and life experiences. And since we're both neurodivergent and happy to skip the small talk, let's just jump straight into a deeper level.
Great.
So, can you tell us a little bit about what fat phobia is? Like, how does weight stigma come into play in healthcare settings?
Well, fat phobia is just another word for weight stigma, and it conveys this message of it being awful. And it is awful because stigma in medical practice in healthcare shouldn't exist. You are ethically and morally obliged to help anyone. When there's a bias against someone just because of how they look or their weight or any other physical trait that you may or may not like or you may or may not be neutral about, then you are not practicing good medicine. You are not giving good health care. For example, let's say an ophthalmologist gets a patient that is missing one leg. He had an amputation, and the patient comes into the ophthalmologist's practice on a wheelchair or what have you, with whichever aid you want. And the ophthalmologist starts making assumptions about the health of this patient just based on the fact that this patient does not have one leg. The patient's coming because he has some eye condition. Okay? And you get this person, this healthcare practitioner, making all sorts of assumptions based on the fact that the person is missing one leg.
Mm-hmm.
I mean, you might think, oh, he has or a problem with diabetes and had to have an amputation, and therefore this person might have an eye problem. We're trained to do that. We're trained to look and make assumptions, but it shouldn't cloud our vision. You know,
Mm-hmm.
we shouldn't just dismiss the person. Oh, you cannot see because you're missing one leg. That's what fat phobia looks like. A person shows up into whichever specialist's practice, and all of a sudden, the problem is because the person is overweight. The person has adiposity in the abdomen, and that makes them have a bone fracture. That makes a person have thyroid cysts. That makes a person have deafness, if you want. Like we've heard in different instances examples that are as absurd as that.
Yeah.
So we call it also lazy medicine, fat phobia. You just take the shortcut, the easy way out. And it's especially pernicious in the public health care setting, in which you have to see a lot of patients in a very short time span. So, what's the easiest thing? Very often, it's things that could be related to obesity or overweight. So, the patient has reflux. That's because he or she is overweight. So, yeah, you dismiss it like that, and more often than not, the physician might have a point, but very often, no. Sometimes they miss a point, and it gets as ridiculous as saying first lose weight and then you come and see me when you've lost all that weight so that I can schedule your colonoscopy. Just like that, but this I won't
Wow.
refer you to the colonoscopy because you're overweight, and that creates all sorts of problems.
Yeah, it's a barrier right off the bat.
Yeah, yeah,
Ah,
that's just like even if there's a relationship between overweight and obesity with a healthcare condition you're treating, you should not just dismiss everything. You have to give a treatment, and very often it's just the excuse to just let it go, let the next person come in. If the person is also overweight or obese, then I have another excuse to just tell the person to go. Shed some kilos off, work out, eat less, and then I go home after seeing the 10 patient quota I had for today.
yeah.
That's how it works.
I believe you because I've also experienced it myself on the patient side of things. Can you tell me a little bit about your own personal experience with fat phobia?
Yeah, sure. Lately, I haven't had any, thankfully, but I've had a fair share of it throughout my life. Probably the most recent one is I have lumbar pain. I I have little space between my vertebrae, and but I actually started having it when I after I lost 40 kilos. I've been weight cycling all my life, and at some point I had lost 40 kilos. I was working out, and boom, I get sciatic pain, and it, ever since that was probably like 11, 12 years ago. Ever since I've struggled with back pain. And at some point, I went to the doctor to get checked. I had an MRI, and I needed physiotherapy. I needed treatment. And the first thing I got is, you should see a dietitian. You're a dietitian yourself, but you should also see a dietitian. It's very funny, my joke, because you could use losing some weight. It will actually help. And yes, we've seen it helps, but that was unsolicited advice.
Yeah.
Did they even think that me as a dietitian don't know that?
Yeah.
Right? And I didn't need a slap on the wrist to shame me for being a fat dietitian.
Oh
and
my goodness.
uh, and yeah, I know. I did go to see a dietitian that was recommended by this doctor, and it ended up being the same all over. I said, you know what, spare me the waste of time here. What I needed were my exercises. Like, it was
Yes.
totally unsolicited advice, and yeah, I didn't like it. But as far as it goes with personal experiences, like every time I go to see a doctor, like I'm waiting to hear that wonderful advice.
Right.
Uh,
That
as
comment that you think immediately is going to be the knee
Yes,
jerk reaction of let's address your weight before we even talk about your valid concerns.
yeah, yeah, yeah. At some point during that time, one of the doctors was thinking about ankylosing spondylitis, which thankfully I do not have, and many other doctors around. Like, they all pitch their opinions, and since I'm in healthcare, like, they all give me their input, and very often it's a welcome input. Like, we're talking about it, and they say,
Yeah.
"Oh no, I don't think you have that." But more than two did say, "Oh no, your problem is not the autoimmune condition. Your problem is your weight." I'm like, "Oh, thank you."
It's just staggering to me when that is the very first piece of unsolicited advice. And patients are fully aware if they've got some weight on.
Hmm.
Patients are painfully aware usually, right?
Yeah.
And you're a healthcare professional and you're receiving this kind of input. So, thanks for sharing about that.
Yeah, and I suppose it happens more to women than it does to men, or men tend to be a bit less worried about it, or they hide it better. Maybe it can be, but I've even heard it from like, from professors. One of the professors in the dermatology clinic told a girl a student girl, like not a
Yeah.
patient, a student of his, you should lose some weight. And it reminded me of the time when I was in medical school for the first time, because this is my second go at it.
Yeah.
We'll talk about that later, maybe. Uh,
Yes.
I had one teacher once telling me, like, it's not acceptable for a doctor to be like you should lose weight, because you have to tell patients that they have to lose weight. So how can you tell patients that they have to lose weight if you are like you are?
There's so
And
much wrong with this mentality.
yeah,
Like you're supposed to be a paragon of perfection instead of a human being.
yeah. And well, being fat is not a choice. It does make you more prone to certain diseases. It does increase your risk of suffering other conditions, right? But it's not something people can easily choose and change. And when people change their weight, then they gain their weight back with a tip. Like,
Yeah, with
50,
a little bit on top of that, right?
yes,
Yeah.
the treatment for obesity has terrible outcomes. Like 95% of the people around that, it's in that ballpark. Over 90%, let's say, regains the weight back in 5 years. Let's talk
Right.
about 10 years, and that's even more.
Mm-hmm.
Right? So you can ask just about any person who's fat if they could lose weight just by taking a pill, if they would do it. That's why the new drugs such as semaglutide and tirzepatide and all these new injectables are so
Yes.
popular, because they sell you a magic bullet, and they are not, because they have horrible side effects. But people are even willing to go through those side effects just in order to lose weight and to conform to the standard, because it is a standard. It
Yeah.
has something to do with health, but uh, in medicine, in public health, you have risk factors, and you have modifiable risk factors and non-modifiable risk factors. Non-modifiable risk factors such as age, ethnicity, things you cannot change, like your chromosomes. You cannot change your chromosomes. So there's things you have in you that you cannot change. And they are starting to think and discuss whether weight and adiposity are modifiable or non-modifiable risk factors. Yeah.
What's adiposity? I'm not familiar with that term.
Ad-
Adiposity.
Adiposity is the amount of fat that you have in your body,
Oh, okay.
that you store. Some people tend to store more adiposity, like more adipose tissue. Adipose tissue is the fatty tissue. So adiposity
Okay.
is like how much fat you have in on you, in and
Okay.
on you.
Thanks for describing and explaining that.
Yeah, no, it's a mouthful. Adiposity.
I can really relate to what you've just shared about fat phobia. Like, I just realized this week it's exactly 16 years ago to almost the day that I was T boned by a reckless driver and was permanently injured in that
Right.
car accident. It's hard to believe 16 years, and I've been in pain ever since. And the medications that I was put on for the pain and for the other symptoms after the accident caused me to gain a whopping 50 pounds that I didn't have before that, right? It came after the accident, and I was really concerned about the rapid weight gain because I was a vegetarian on a raw food diet. I was actually vegan at the time. I had been active. And then, of course, with the limited mobility and the pain and the constant rehabilitation efforts and the cocktail of medications that I was being given, I was just packing on the weight. And so, the very same doctor who was prescribing me these meds that I was concerned about, instead of listening to that, fat shamed me relentlessly. Like, it really impacted my life. Like, you can hear my voice is really hard to talk about. And like, I was explaining about the weight gain. You could see it on my body. Like you could see the water retention on my hands, my arms, everything. And I didn't know what fat phobia was at the time, but I felt very attacked and very insulted because this doctor actually said something pretty shocking to me. They just matter of factly, really coldly said, "You know what? You would never have been hurt in this car accident if you were fit." And I said, "I'm sorry, what?" "Well, you're fat. That's the reason you got hurt. You're fat." And I just said, "You have been seeing me for years. You know that I've gained this weight since the accident, and I'm talking to you about the side effects of these drugs." But this doctor said, "Fit people don't get hurt in car accidents. If your body was fit, you would never have been hurt." As if that is some kind of protection shield, that the human body in fit and thin form is impervious to a, I don't know, ton of metal hurtling into your car. I didn't even like know what to say. And I tried to, counter it with, "Well, you see, I did gain weight after this medication." And this doctor just kept saying, "Nope." And I remember leaving that doctor's appointment feeling really in shock because this doctor kept saying, "You're just obese. You're just obese. You're fat. You need to do something about that." And I was already feeling like my whole life had changed. I was having trouble. I was learning how to walk upstairs again. I was learning how to shower and wash my hair again, doing it all by myself with no support. And then to be called fat and obese, I started to be so affected by it. I didn't want to leave my house. I didn't want to see anybody. I started to get this distorted impression of myself. I didn't want anyone taking pictures of me. I look back at pictures at that time, and it's absolutely clear to me. Like when you see the before and the after the accident pictures, you can see the impact that lack of mobility had, but also, most especially, the medication, the cocktail of drugs that I was taking. And to prove that point, even though this doctor kept saying, "Nope, it's your own fault. You're just fat. If it goes past your lips, it'll go on your hips." And
Oy.
so, yes, this is an old, very sexist kind of statement about diet culture. And I explained, "Look, I'm on a raw food diet. Here's my food journal." Didn't believe me. "There's no way. There's no way you eat like that and you're like this." I said, "Well, I'd like to adjust the medication." Instead, they just wanted to give me more. And I finally just went rogue and stopped the medication cold turkey after several years. And Fernand, within 2 weeks of me stopping these pain medications, within 2 weeks, 20 pounds came off my body without any change to my diet or to my activity levels, which were still, I was still going through rehabs and all the different ways to recover. There was no significant change. 20 pounds in 2 weeks came right off my body. And within 3 months, 60 pounds in total were gone, completely gone. And again, with no change to my diet, with no change to my activity levels. It was so rapid and so obvious to me that medication had a huge role to play in this. I just wanted to bring that up because, when you're vulnerable and you're in a situation like that and a doctor body shames you and fat shames you, then it can cause that body dysmorphia, not recognizing what you look like realistically and that unhealthy fixation with your weight. Because, I still struggle with that to this very day. Every time I look at pictures, I go, oh, I didn't realize I look like that, and it's better than I think that I look. It's like I don't recognize that person. If I look in the mirror, I think that I am so much larger than I am, and I do hear that person's voice in my head saying, "You're obese, you're fat, it's your fault." So I just wanted to share that because, it's important to treat the overall condition and not add more anguish to a patient's journey.
Yeah, very very often it's just like as if the person with obesity or overweight, like let's say the fat person, nowadays fat people don't want to be called obese or overweight. We try to reclaim the term fat. I'm fat. I'm not obese. I'm not overweight. I'm fat.
Yeah.
Uh, um, yeah, it's as if fat people had to do an additional task on top of getting better. Let's say in the case of your rehabilitation after the physical trauma that you had, you were encouraged also to lose weight. Like you had to do something else in
Yeah.
order for it to be equal to what thin people do when they get hurt, when they have a car accident. And
Oh,
it's,
but thin people don't get hurt,
yeah, oh yeah, no, fit people.
right?
No,
That's
that's
what this doctor said.
yeah, I mean, I'm I might be burned for what I'm gonna say later, like because I'm a med student, I'm a dietitian, I'm a med student. I'm not yet a doctor. But saying that fit people don't get hurt, it's probably one of the most ignorant things I've heard regarding weight stigma, because it's simply not true. Like it just comes to mind that, for example, fat people tend to be protected from fractures, bone
From
fractures.
impact, yeah.
Yeah,
Yes.
it's actually a thing. Like
Yep.
we've seen that in the elderly population, like having a bit more of fat is actually protective. I'm not saying
Mhm.
having a lot of excess fat, but having some
Mhm.
fat can be protective. So
Yeah.
it's not even true what this guy is saying. Like being fit protects you from car accidents. Like
Yeah.
it's as if he were saying that being fit protects you from the laws of physics.
Well, exactly, that's why it was so shocking. I couldn't even speak because when I finally could speak, I was like, "You do realize this weight came with these medications, right? There's a before and an after,
Oh,
right?"
you went on and Googled the effects of the medications that I gave you.
Oh, yeah.
Oh,
Then
shame
it's
on
like
you.
yeah, then it's like, "Don't question me. Don't challenge me. You're just fat."
Yeah,
And
yeah,
here, would you like some antidepressants too with your fatness?
yeah.
Like, okay.
No,
Because they don't also make you gain weight.
yeah, no, but
Right?
terrible,
Yeah.
terrible, terrible. And yeah, I mean, in terms of dysmorphia, thinking about how you see yourself, and how that impacts patient care. Like it reminds me, there was once this publicity from the Mexican Social Security Institute, where it would say that fat people see themselves thinner than they actually are, which was completely evidence-less. Like there was, it was just something that someone came up with, and probably someone thought, "Oh, it's so cool, it's probably true. Let's just put it in a
Yeah.
poster
Yeah.
and all over Mexico." And
Propaganda.
yeah, I do not think that anyone who's fat thinks they're not fat. We are
No,
reminded every day about it,
absolutely.
from the moment we're getting dressed. Uh,
Yeah.
and people who are very fat, they tend to struggle to even find places to sit, doors where
Yeah.
they can fit, hospital beds. It's rare to find a hospital bed that is made for someone who's fat, with a large body, who has a very large weight. They're not made for that. uh, MRI machines, CT scanners,
Yes.
uh, you name the radiology equipment you want.
Yeah.
They even tell you, like, you cannot put someone who weighs more than this because it will break. And I, I don't think that actually dysmorphia is a situation, because we know it. We are reminded of it. We don't think we're thin. If anything, is the other way around. We think, as you
Yeah.
said, we're fatter than we actually are.
Yeah.
And yeah, it,
I've still to this day, even though that was again 16 years ago when I was injured and it took many years to recover, but let's just say even 10 years ago, like there's such a disconnect between what I think my body is now versus what it is. And, I'm an average sized person and I get in those MRI machines quite a bit. And that's a pretty tight squeeze. And to not be able to access these types of equipment and diagnostic tests is quite a scary thing to think about for anybody who lives in a larger body.
yeah, and I will tell you something. It's actually a very worrying situation. One of the institutes here that has a very large obesity clinic. I mean, Mexico has a very large fraction of its population that has uh, quote unquote obesity in the statistical.
Yeah, the BMI chart type of
Yeah,
way.
yeah, yeah, yeah.
Yeah, yeah,
Which has a very interesting history in itself. I encourage people listening to us to go look up how the BMI situation was built.
yeah,
It's very interesting and very worrying. But if you have a large prevalence of quote unquote obesity and overweight, and you have a clinic in one of the top-notch research institutes of health of this country that has a lot of obesity, then you shouldn't be saying things like that. Um, Things like what I'm going to say. They told us we don't have equipment for people with obesity. Our scales go up to 200 kilos. So if we have to weigh someone that weighs more than 200 kilos, which exists, um, we need to weigh them at the place where we receive supplies, like, like where they bring in,
The industrial scales?
yeah, an industrial scale, but
No.
they have to go out of the place where they're weighing them, and like, let's go where they bring in the apples and the, you know the stuff
Yes.
that we need to operate the hospital.
Supplies, yeah.
Yeah, yeah,
So
yeah.
dehumanizing, right?
Yes, yes. And you say, okay, you are one of the top-notch obesity clinics of the country, and yet you have to send your patients to be weighed to the warehouse scale. Okay, to begin with, like, there's so much wrong about like having to go weigh someone and talk a lot about their health based on their weight. But
Yeah,
okay, if you're gonna do it right. At least have the
yeah.
scale in a place in your clinic. And you go to any clinical medicine ward in Mexico, or in any place for that matter, it's any place, like,
Yeah.
you need to take blood pressure from your patients, and you don't have cuffs for taking blood pressure from patients who are large, and it doesn't fit. And then there's this tug of war, like, oh, I have to put it on, and I have to,
Try
like,
to adapt it.
adapt it and
Yeah.
maneuver over the patient, and everybody's looking and everybody's watching, and the patient feels observed. And why don't you have a cuff for large patients? It goes as far as, uh, probably one of the most heartbreaking things I've ever heard. I once had this patient. As you mentioned, I work in oncology, and I had this patient who had struggled with her weight all her life, according to what she told me when we were talking
Mhm.
for the first time. But what I was seeing was not someone who had struggled with her weight, because she had lost already so much weight. Because this young woman had colon cancer, and she couldn't eat anymore. She had a bowel obstruction, so we had to feed her IV. And she felt undernourished, she felt weak, she had lost so much weight over the course of her disease. And the first thing she tells me, just after I told her that I was going to feed her IV, it was like, please, please, please don't overfeed me. It's the first time in my life I'm thin. So there's the silver lining of cancer, is that you lost so much weight for the first time in your life, that your metabolism got so reprogrammed that now you feel like you fit in and you don't want to gain any weight.
Mhm.
Okay, you want to gain weight now, and it will be hard. It will be the opposite now.
Yeah, to survive, we need you to gain weight.
Yeah,
But all those messages that are being absorbed from probably childhood and throughout media and loved ones and medical settings, it contributes to eating disorders or body dysmorphia or other just distorted senses of our value
yeah,
being connected to how we look.
yeah.
That must have been so hard for you as a professional trying to help. It must have been heartbreaking.
And it was said tongue in cheek, but not tongue in cheek. Like it's haha, it's the first time I'm thin, but uh, you could see inside that she was happy to be thin,
Yeah,
emaciated, if I may
yeah,
say. Like,
yeah,
it was undernourished. It was not like healthy thin, but it's better than fat. And that's the thing that, uh, and if you bring that up, if you want to go against that, then you are an enabler. You're enabling obesity. You're telling people
right.
it's good to be fat. And I mean, we don't owe health to anyone. Like, you can choose whatever you want to do with your life and be happy with it. But we
Yes,
do have a double and triple standard there.
right. As healthcare providers, you
Yeah,
want the very best outcome for your patients And I can see how that can get tricky as well, right?
Yep. Yeah,
Yeah.
definitely.
Fernand, I understand that you're all about providing dignified care for your patients. Can you tell me what it's like to work in healthcare where barriers exist for both the patients and the personnel who may be caught up in systems while trying to help?
Yeah, for sure. I mean, barriers for patients. We've just explained one that is close to me, but there's just many. If you talk about any functional disorder meaning it's the new term for diseases that you cannot actually find an anatomical cause or an anatomical situation going on. But for example, IBS. IBS is a functional disorder in which your intestine looks okay. If you biopsy, you don't see any problem with it anatomically, like in terms of morphology, how it looks, the cells, everything's fine. But it just doesn't work well. It just makes you feel bad, right? You're bloated all the time, you have to go to the bathroom all the time, and there's no apparent cause. That's a functional disorder. Fibromyalgia is a functional disorder. People with those diseases face a lot of barriers because there's also the mental health stigma, and they've been associated with depressive disorders, anxiety disorders. They used to call it long ago somatization, and oh, you're somatizing this, like you are, like almost you're making it up to.
Psychosomatic, is that where that comes from?
Yes, it's psychosomatic. They almost make it sound like it's being invented by the patient to be seen by the
Yeah.
doctor. You know,
Oh, yeah, it's
so
in your head.
yeah,
You
it's in
have
your
no
head.
reason to be here.
You want to, you just want attention. That's what you want. You just want attention. And then you see patients with functional disorders coming into like a gastroenterology clinic, and they are people who are very often tired of their symptoms of their disease, of being told that it's just in their heads. And yeah, they are combative. People with functional disorders tend to be tired of going to the doctor and being told that they are not sick, yet they don't feel well, they don't perform well. So yeah, they are combative, they answer back to the doctor, so they're labeled as difficult
Difficult
patients.
patient, yeah.
Yeah.
Having been told it's in my head for 20 years.
Yeah, and there's even neurological functional disorders. Like there's people who actually have seizures that do not have like the symptoms that you would find in someone with epilepsy, or people who have movements, tremors that you wouldn't be able to diagnose otherwise. You excluded already every other disease that there is, every other neurological disease. Then you have a neurological functional disorder. People think it's, oh, it's just made up. They just want the attention. You don't get it. They come here to get the attention. They just want to be given a prescription, and it's not the case. Patients
No,
would rather not feel that.
and would rather not have to go
Yeah,
asking for help.
there's barriers in that aspect, but there are other barriers that are more explicit. Like you might even find clinics that are not accessible for everyone, clinics that still are missing elevators, ramps, or they built a ramp that is just like they have a flight of stairs, like 3 or 4 steps, and they just put a ramp on top of that, and it's a ramp with a very high slope. You could find countless examples of that. And for personnel and providers and students, there's also quite a few barriers to not only to provide safe and good quality care for their patients, but also to study. Like, I'll give you an example, something, uh, being able-bodied, I don't, these are situations that don't come into my head. uh, and when somebody shows them to you, you say, this is horrible, this is horrendous. I have a colleague studying with me who's on a wheelchair. She has no mobility in her legs, and she was doing a surgery rotation, and she had trouble with her preceptor because she didn't want to explore inguinal hernia. For exploring inguinal hernia, you have to manipulate the genitalia of the patients. And the doctor just wouldn't have it. Like, why are you not doing it? This is something you need to be able to do to be a doctor. And yes, you need to be able to diagnose inguinal hernia to send them for surgery. But the doctor never thought that the problem for this girl was that she wanted to wash her hands between explorations. For us, it is very straightforward. You just wash your hands.
Right.
The sink
But
is
for,
right next to you.
but for a wheelchair user,
But for a wheelchair
yeah.
user, it was a problem. She couldn't wash her hands in between because it was very high, because she had to move around. And it was simply not an option for her to go wash her hands elsewhere. The sink in the doctor's office was very high.
So this lack of accessibility, she was getting criticized for the barriers in between for her trying to do this procedure.
Yeah, and she was ashamed to say why it was. Like, she was being labeled as a difficult student, and if she just starts asking for accessibility, like, oh, I need to wash my hands, because it's also good patient care.
Yes.
But the doctor was, oh, you're difficult, you're a prude, you don't want to be doing this and that because you feel
The
special.
assumptions, yet again, we
Mhm.
get these unconscious biases like
Yep.
this female doctor is being a prude or is being difficult. It's very
Yeah.
interesting, right? Because there's gender bias heavily embedded, as we know, in healthcare
Oh yeah.
professions.
Yeah. It's still a bit of a man's world. And female medical students are still seen as prey by senior male doctors in some cases. It's not unheard of. Like, they're put in this position where there's a power structure led by men, and very often what these men ask in exchange is harassment, sexual
Yeah,
harassment.
absolutely. And there are certain doctors where I'm from that have nicknames and reputations for exactly that, for targeting these young healthcare workers who are female.
Yeah, those are like the big things that you see still being problems, but you do see them in certain specialties because of the type of profiles that certain specialties tend to attract. And then there are specialties that tend to attract more males. So you have a very high male to female ratio. Mix the statistics, and then you have specialties that become really problematic. A very narcissistic male dominated environment, it becomes very hard for them to succeed there. And the successful ones develop very, very, very tough personalities to be able to cope with that.
Internalized misogyny is a coping mechanism. You
Yes.
know how they say, oh, it's eat or be eaten type of mentality. And I've seen that in the business world as well.
Yeah, and it also depends on the hospital too, because some hospitals have successfully implemented very good policies to protect female students and other female practitioners as well from sexual harassment. But there's still a long way to go. Like, even in those places where they've made a few steps in the right direction, there's still situations where you find horrible things. And
Like a hostile or a toxic environment.
yeah, and even if you have this policy in place, you will hear a certain doctor say something like, I don't care about that policy, I'll do whatever I want. They've been there for ages and they won't sack them because they're unionized, and it's more expensive.
Power and privilege, right?
Power and privilege, and then there's money behind that. And
Hmm.
it like this thing that it's very expensive to fire that person, so we won't fire that person.
So, Fernand, how does it feel to witness patients being dismissed or judged, if you've witnessed this in your time in healthcare?
As a student, it's you feel powerless. You feel like there's not much you can do, and you feel like the patient's also painting you with the same brush that the doctor's being painted. And sometimes you think, oh, I wouldn't have done that, I wouldn't have said that. Even sometimes when the doctor is right about the judgment, but the way he's conveying it to the patient makes him feel bad, Like sometimes there are of course difficult patients every now and then, and there are of course instances where patients are just being very demanding, but you should never dismiss the patient just like that. And very often you just want to do it yourself differently, but you can't, and you're there sitting at the back of the doctor's office witnessing it, and you're just part of the team that dismissed the patient, and you just feel powerless. And you do learn that there's things you don't want to do, like that's also part of the learning experience. But you need to be open to say, okay, maybe I don't know enough about medicine, but I do know enough about how to be a good person, and this is not something I want to do in the future, and maybe this is not the role model I need. And very often there's this person that is this huge personality in medicine, and then you see them how they treat their patients, and you're very disappointed on them. Yeah, and maybe like there are reasons why things are the way they are, which doesn't mean they're right. But as I mentioned, in a time constrained healthcare setting, it's very easy for those things to happen, to dismiss patients and dismiss their concerns and dismiss their pain and not being able to have an actual conversation. But you do need to take the time to listen. And sometimes it's irrelevant for you as a clinician what the patient's telling you, but very often there's a lot of good information that will lead you to a better diagnosis if you just sit back and listen. And
Hmm.
sometimes we are impatient.
Yeah. And on the patient end, they're feeling unseen and unheard and rushed out the door.
That's something we see happening on a daily basis. It is rare in the public healthcare setting to find someone who actually is willing to take the time to listen to you. And we talk a lot about prevention and primary healthcare and primary level of attention and community healthcare and whatever. We don't do anything of that. Like, we just want to get things done quickly. We don't listen. And then we end up having patients with complications, and we end up having patients who don't want to come to see us because we dismiss them.
Yeah.
And when time comes, they end up going into the ER with very nasty complications, which could have been prevented. And very often, all they needed was one of those gatekeeper doctors actually listening to what the real problem is.
Yeah.
And they tell you in med school all the time that if you listen to your patient, if you explore the patient correctly, 90% of the times you'll get the right diagnosis without having to do expensive tests.
Yeah. And without the patient declining to a point of losing their quality of life and maybe losing abilities, losing their health. I've been one of those patients who said, I cannot go back. I can't do this anymore, after barrier after barrier. And then suddenly you're at a point where you're in the ER and it could be so avoidable. So that
Yeah,
must be hard for you to witness that, right? I appreciate you
it's
talking about
hard to
it.
witness it, and it's hard not to get trapped in that way of practicing. It, because then you are so burnt out by the system where you need to do all these things and they expect you to to be human, yet all of a sudden you're part of this big machine where you're also dehumanized. And then the problem is, capitalism.
Yeah, it's cyclical.
It's patriarchy, the patriarchal structure of it all. It's capitalism. It's all about numbers, and it's all about productivity, and it's all about how many patients you see and how much it costs. So you have to see as many patients as you can in as little time as you can and with the least cost possible. So
It's like an
it's,
impossible equation.
yeah, yeah. And then where you have this dual healthcare system, then you have this double standard where public medicine is just like what you get, and beggars can't be choosers. Like, oh, well, like, I don't, for example, if you're well off, you don't need to go to the public hospital and you can get all your tests done without even needing a referral. Like, you just go to the radiology clinic and you say, I want an MRI of my head. Okay, pay $2,000. So then you have this social injustice.
Right. Fernand, can we talk more about your navigating medical school with ADHD? Like, what's that experience been like for you?
Oh, well, having ADHD in medical school has. Uh, I've only known I've had ADHD for a few years. I'm almost 38 now, and I was diagnosed when I was 32. So yeah, when you're diagnosed at 32, like it all makes sense, it all fits in, but there's so much that has gone through and that you can no longer change. But if I had known I had ADHD when I was younger, I maybe would have done things differently. I started medical school when I was 34. In Mexico, medical school is not something you do after college, it's something you do after high school. Like in Quebec, like there's no college. You just go into whatever you want after you finish high school. Like you can go into law school, engineering, whatever. And I had chosen to do medical school when I was right out of high school. I was accepted in a good medical school, and I was very happy at the beginning. I've always had my own way of studying. I've always struggled with reading. For example, if you give me a book and you tell me you have to read this chapter for tomorrow and I'll make you a quiz, I will fail the quiz because I won't read the book. I will only read a few pages or paragraphs. And if I'm not interested in the book, I will not grasp a lot of it. I will just stay in one page for ages and look at the same paragraph and keep going back. And I've read this page 30 times, but I haven't even gotten the a gist of what it is. That used to happen to me a lot when I was in high school, and I thought like, "Oof, like I'm just lazy. I'm not interested in this." And back in the day, there was no shortcuts or Google or anything where you could get a summary already done for you. You just had to go through it yourself and read it and get quizzed. And I wouldn't do well in that. I would compensate with many other things. Like they would ask me to write something. It would take me forever to write it, but I would write something with good quality and they would give me a good mark for it. And exams, I'm not that good of an exam taker, but I survive. If I pay attention in class and it's not a lot of information, I can just survive with that and I will get a good mark. So that's how I would go about it.
Is that your memory? Like, do you go by memorizing what you're hearing or absorbing
Yes.
or looking at? Okay.
Yes, if I sit through a lecture where I'm actually paying attention and the professor just fits with my way of learning, I don't need to study later because it just sticks there. And then I don't need to read through my notes or memorize anything. And high school seemed to fit with the way my brain worked. And in high school, there's a lot of emphasis in maths and chemistry. Like, if you understand that, you don't have to study it again. It, you just got it, you apply it. That's it. Medical school was not like that. Medical school was learn information, regurgitate all this book in a quiz. And very often we didn't have professors who liked teaching. They liked to talk about their lives. And they would say, the content is in the book. Here's the syllabus. You read, you take the test. I'll talk about my life. And it was not just one, it was three or four professors like that. And on top, you had to read for the other professors who would tell you, like, I will test you on what's on the book, but I cannot teach you everything that is on the book. I'll teach the main points, but I can quiz you on anything I want that is on the book. So you had to read a lot. And for me, that was a nightmare. And I was used to getting very good marks in high school, and my marks were not that good in medical school. And that was like a big bucket of ice on my face because I used to think I was a good student, that I was managing well. Now I know I had ADHD and that I was just coping with my own ways, but it just didn't work for medical school. I was overwhelmed. So I quit. I quit when I was 20, and I didn't think of going back until I was 34, when I realized that's what I wanted to do. In my way of studying, I've always thought that I like to cut corners, and it's not about cutting corners. It's about the way my brain's wired. I
Yeah.
still can't read stuff, so I have to find ways to make it easier for me. And for example, for me, listening to someone saying the information is way better than just reading it from a book. And
Hmm.
if they assign me, oh, you have to do this reading for the next day, I won't do
Mm.
it. I just rather
Yeah.
watch a video. And nowadays we have videos. There's 1,000 platforms around that will give you all the information you need. It's like the thing you need to know from the book. It's just you're
Yeah.
not
Like,
reading it.
well, it sounds like you've been adapting your learning all along, even when you were a kid.
Yeah, you learn what works for you and what doesn't work for you. But when you're young and sort of immature, like, not being able to do what a senior professional is telling you to do is very discouraging. And if I was not able to read from the book, then you're disappointed that you cannot read from the book when everyone else can. And then I must be a failure because I can't do it. I remember that, uh, uh, because I've always suspected there was something going on, because I can read when I'm interested in it.
Hmm.
The problem is that when I need to study for it, I'm not interested in it. So, uh, if I find a book that is interesting or worth reading, I'll finish it. I'll devour it. But I have a lot of books that I've bought thinking that I would be interested in them, and they just end up decorating a shelf.
Yeah, they're just staring at you from the bookshelf. I have some too.
Well, once, because going back to the whole neurodivergence situation, and particularly the inattention symptoms of ADHD, I'm not hyper. I don't have hyperactivity. I'm mostly
Same.
inattentive. It mostly happens when I'm stressed. When I started practicing as a dietitian, helping a doctor that practices as a dietitian here in Mexico, I would struggle, for example, with documentation, like writing down the clinical note or writing the doctor's orders. And it's not like I struggled with doing it. I would do it, but then I would find out that I did it wrong. And that can be very dangerous because you can write the wrong number.
Hmm.
And fortunately, there's a lot of like systems in check that will help you with that. And I think there needs to be double checking systems, not only from you. Like, if I read something that I wrote wrong, I will read it again, and very often you might not even realize that it's wrong.
Hmm.
So what I found that works for myself is, if I write an order, I will go with a nurse, and I will with a nurse that is in charge of my patient, and I will say, does this make sense to you? And
Right.
she will go through my order and say, yeah, it makes sense. Or she would tell me, you know what, why don't you put this, because otherwise someone might get confused. Like, clarifying and communicating, it's actually one of the international goals of patient safety. I think it's goal number 2, and it's avoiding communication errors. So you have to double check, and it's not double checking by you, it's double checking with someone else. And it's very good that that exists, because it prevents a lot of mistakes from happening. And sometimes, even if you're not neurodivergent, the way you want to write something or express something to someone else, for you it makes sense in here, but it doesn't make sense for the other person. So you need to double check, and that has helped in my particular case. And that brought me problems when I was doing my internship in dietetics, because you're overwhelmed and you do what you can. And in this overwhelm, you don't ask for help because you don't want to come across as incompetent. And that's a bit of, like, let's say, professional immaturity. And I made a lot of mistakes when I was,
20 years old.
yeah, yeah. And I started getting worried, and that's when I first looked for help. Nowadays, it's a different world where we think about neurodivergence differently, but it all comes hand in hand. Like you're wired differently. And if you are inattentive in the healthcare setting, that will come bite your ass later. Sorry if I say that, but you do have to know that you're inattentive and you have to rely on double checking by someone else. And if you're ashamed of it, you are doing it for the patient's safety, for the sake of the patient. And when you write something, you're writing it so that other people understand it. You want someone else to carry out your order, your indications.
Yeah.
Okay, they say know your limitations and it's okay. So before it comes bite your ass, you double check with someone else to read your
Yeah.
things.
Well, and
And
you're relying on your teammates, right? It's all the collaborative part as well.
yes, yes, it's part of that. And you would be surprised about the amount of people who have inattentive errors when writing down indications for nurses or for whomever. Uh, like you can read from like the top-notch doctors what they write, and you might not even understand it. And I tell you this: this is why the international goals of patient safety exist. And the second one, that is about communication, asks you to double check if you don't understand. And a lot of mistakes in the healthcare have to do with miscommunication. And a lot of mistakes come from assumptions.
Yeah.
And that has been probably one of the worst struggles I've had, not making inattentive mistakes. I wouldn't say I'm there yet. There's still a lot of things that I have to be very careful with, especially when I'm working under stress. But those are my insecurities. I think like there's a disaster waiting to happen, and
I think that's a very human and neurodivergent feeling
yeah,
or worry.
yeah. I'm honestly worried. Like, and there's this imposter syndrome thing going on. Like, oh, they will find out. They will find
Yeah.
out that this is all a facade. That deep
Yeah.
down, I'm just this mess. But we're all messes. It's normal. Where I find I make the most mistakes is in the menial little tasks that you wouldn't like. You already climbed the mountain, but then you
Yes.
trip over a rock and you hit your head, and
Yep.
you have to be very systematic to not make those mistakes.
Yeah.
And it's a big deal.
And that's why they say the devil is in the details, I think.
Oh yes, oh yes. And it's mostly in that little thing where you end up making a mess out of something very small.
Yeah.
And people with ADHD, we tend to rocket through things. We struggle to slow down, especially to slow down in situations where we're not interested in the task and you just want to get it done. And that's when you make the mistake. And I find there's like this danger zone when you start feeling confident about something, but you're still not there yet. That's when you make the mistakes. And then when you know you can screw up and you know where the mistakes can come from, that's when you slow down a little bit and you start thinking about the potential consequences of these things, and you start understanding why they are there in the first place.
And
And
you said about self-awareness, you're very aware of those gaps that you need to address. So then you create these systems.
and it comes back to this situation of the humanized machine of healthcare practitioners. And when you start feeling burnt out, when you start feeling anxious, when you start feeling overwhelmed, that's when mistakes will happen. And they happen if you're not neurodivergent, and they will happen more likely if you are neurodivergent. That's where I want to underscore the importance of healthcare practitioners to rest, to not be overwhelmed with patients. I know there's a lot of people to see, a lot of things to do, but We need more people, we need more human resources, we need more money to address these things, we need more foolproof systems and computers that can help us double check and all these things, so that healthcare practitioners can rest and can actually dedicate their time to seeing patients, and the less interesting part, still do it correctly and taking care of themselves, of their mental health, of their physical health, which we often can't. And that's when mistakes will happen. And that's why we need to be prepared. And just this, in the same way that astronauts and army people take care of themselves before going on a mission.
Yes.
But we do not, like, we don't practice what we preach. And that's where the chain breaks. So we have to be extra careful and practice a lot of self-care, because otherwise it can be disastrous.
Thanks so much for sharing that. I have another question for you. When it comes to treating your patients with dignity and care, what's the approach that you take as a doctor in training?
It's just thinking that it may be you in the on the other side of the desk. And I like to think, like, what would I want, or how would I want to be talked to about this situation, because they're coming to get help from me. Okay, and I might not have the answer, but I might be able to reassure them in different ways, and I might be able to channel them to the proper professional, and I might be able to say something that will give them a bit of peace of mind. You know, I mean, I'm not there to sugarcoat everything.
Of course.
I'm there to be humane and talk with the truth. But I always think, like, if I were the person sitting on the other side of the desk, would I like this treatment? And if the answer is no, like, you can even apologize. Like, you can even say, let me rephrase it. What I meant to say is this. And you can always take a step back and then move forward. And also realize that not everyone's going to like you. And you give your best, you do your best, and you still get very, very, very unpleasant people there.
Right. So it sounds like to me humility and patience are two things that would
Yeah.
be part of your approach.
And realizing that there will be some sour apples here and there, and that doesn't make the next person coming to see you less worthy of good attention and good quality of care. Like, you can be nice to the next one. It's
Yeah.
separate.
And what about that curiosity too of, obviously there are people who are just completely unpleasant and difficult in any appointment they ever go to, right? There are
Yeah,
people who are like that. But as doctors too, knowing that you have patients that have been put through a meat grinder of this process, and maybe by the time they've reached you, they're in so much pain, their trust feels like it's been destroyed, that it's an absolutely horrible experience for them. So then they may be presenting with that negativity of their own trauma, I guess. Do you ever get curious about why a patient might be presenting that way?
yeah. I mean, working in oncology, it's a very common thing, and it's hard. It's hard to, like, not make it personal, because there's also people who they've been through a lot. There's a lot of colleagues and doctors and nurses who are not very nice to them, but the patient's feeling so bad that they don't dare to do anything to those who are called to them. But then there comes this smiley, warm guy to be nice,
Oh,
and they're like, oh, we say in Spanish, it's not the one who made the problem, it's the one who's going to pay for it. Like,
right. They
it's
lash out, but in the wrong direction.
in the wrong direction. So sometimes
Hmm.
it's hard to, like,
Hmm.
to process that, and think it's not personal. But that's something where I still have to work a bit, because I find it hard not to take it personally, and it awakens certain insecurities. But I try to rationalize and think, like,
Yeah.
sometimes I'm just seeing the tip of the iceberg, and I have to
Yeah.
rephrase and take a step back, as I said. And what has worked for me is not confronting, but asking.
Yeah. Yeah. For your peace of mind,
Yeah,
but also in case there was something you could learn from it and adapt,
yeah,
right? I'm not envious of you because I could not do what you do. I would I would take it to heart.
Yeah, but it also, we also need to be humble and to be able to listen. You need to have some feedback, and if there's tension in the relationship between you and the patient or client, you need to be humble and accept that maybe, just maybe, I might be making a mistake here, or I might be doing something that I'm not aware that is bothering the other person. So what if I just go and inquire about it, and see what the problem is? And sometimes there's no problem, it's just what it is. And
Right.
sometimes there is a problem and you can learn from it. But it's communication, it goes both ways. And patients are there to hear something from you because they need your help, but you also need to be able to help them, and to help them find what they need, not what you need, what they need. And the only way
Mhm.
of knowing that is by asking and by communicating.
Mhm. And also I think that understanding there are different neurotypes and people who are coming to you who have completely different communication styles or other disabilities that impact how they interact with you, that whole anti-ableist approach is super important, and that neuro-inclusive approach. And I know we're not quite there yet, but I'm encouraged to hope that that will take more hold in the future.
Sure.
Yeah. Fernand, we have talked about so many different things, and you've been so generous with your time. I've got just a couple more questions for you, and this one's a fun one. So, for the Finding Avalon playlist, what is a song or two that you enjoy that speaks to your experience or your thoughts on disability, and why? Like, are there any lyrics that might stand out in these particular songs?
Oh, it's a hard question, because for me it's very hard to pay attention to the lyrics of a song. I like the music, and very often what I listen to is the music and the voice and the combinations of the sounds. That's what I like in a song. So,
Hmm.
but there are a few songs here and there where I can listen to the lyrics and relate to them and love them. Two recommendations that would make me think about disabilities and all these conversations we've been having. One that comes to mind right away is "Creep" by Radiohead, and
Such a good song.
it's a really
Such a good song.
it's a very good song. It has very nice a very nice music and very nice sounds and combinations. But what makes it stand out for me is the part of "I'm a creep, I'm a weirdo, what the hell am I doing here? I don't belong
Hmm.
here." That's like the sort of internal dialogue that you keep having as a neurodivergent person, and like trying to navigate any situation. And if you saw me out and about, you would say, "Oh, this person's not neurodivergent." Uh, you wouldn't think I'm struggling with ADHD, but deep down I am. And it's something, this feeling of inadequacy is there. And I think a lot of us have it.
And feeling different, and not just feeling different, but knowing that you're different,
Yes.
knowing really deep in your core. Like you said, you were in your early 30s before you learned that you had ADHD, right?
Yeah.
So that's 3 decades of living on the planet, feeling different and experiencing the world in a very different way through a different lens.
Yeah. Yeah.
Yeah.
And often I think, like, wow, people either think I'm smarter than I am, or people think I'm dumber than I am.
I can relate.
Yeah, yeah. Like, and then you see people being like, "Oh, you've been doing so well so far, but then you made this mistake,
Yeah.
and it made me question everything about you." I'm like,
Yeah.
okay, yeah,
And you know that moment, right? You know that moment when they get this kind of click of recognition in their eyes, like, "Wait a minute, you just went off script on something." Like, You just glitched. I used to have people say to me, "What are you on?" And I'm like, "What do you mean, what am I on?" "I'm on the spectrum, man."
Yeah.
It's called the spectrum.
Yeah, what just happened there?
Yeah, it's really, it's almost like, what did
Yeah,
you just say?"
one day my boss calls me and she says like, "Oh, they just called me from the hospital like to confirm this instruction, this order, and you didn't write that, did you?" I'm like, "Oh, yes." Yeah, that was me. And then you say, "What the hell am I doing here? I don't belong."
Yeah. What is the other one that you have for us?
I was thinking about "Crazy" by Alanis Morissette,
Hmm.
especially the verse, "We're never gonna survive unless we're a little crazy," and that
Yeah.
that that's true. Like, it's everything's a mess, and you do need to like sometimes allow yourself to, well, to survive, and but crazy good, not crazy bad. Like, which makes me think about what's crazy good. Like, crazy good is actually rare nowadays. Like, actually caring about not hurting someone is,
Radical now,
yeah,
apparently.
yeah,
That's quote unquote crazy.
yeah. I,
So edgy to have empathy.
yeah, yeah, it is a big deal to have empathy nowadays,
Yeah,
and everyone
I
talks
know.
about it. I don't think anyone wants to hurt anybody else, but sometimes hurting someone's seen as collateral, and at some point having collateral became valid, and it's not. Like, if you can do it in any other way, then it's not valid.
Well, I'm going to add that one to the playlist as well. I love getting recommendations from my guests because I love music and I love getting the perspective of my guests because those are two recommendations that really speak to how you feel. And I appreciate you sharing it with me.
Oh, anytime.
So, Fernand, what is a misconception about disability and how can we correct that narrative?
Mm, uh, well, I think a lot of people don't feel that they could have a disability, like they have the right to have a disability.
Mm-hmm.
There's this tinge of victimism attached to the fact that you might have a disability,
Yeah.
and
And that's internalized ableism, right?
yeah, yeah, yeah. Or I don't want people to think I'm asking for special treatment
Mm-hmm. Yeah.
when I'm not. I'm just asking for the same as everybody else is having.
Yeah. And those are the messages that we get from just being in the world, right? Media, jokes, movies, the news, what your uncle might say across the dinner table. It seeps in. And I remember after my car accident, I started to really reconcile the fact that, well, this incident did disable me. And it took a long time to get to that point. I said, I feel like other people have it worse, and I don't feel like I should say that. Maybe I'm not disabled enough, or maybe I'm just not being tough enough because you're told all these
Mhm.
messages, right? I was actively given that advice, and that made me feel so ashamed. And I remember keeping it to myself and suffering in silence without the help that I needed for like over a decade. And even though I was still working to advance disability inclusion, I had this internalized ableism from society and what people were saying. And then that advice of, if you say it, your whole world will change. But guess what? My whole world changed the day that car crashed into me.
Yeah, it is a thing that happens. Um, People don't want to be seen as vulnerable. You're not allowed to be vulnerable, to need something or to need help.
Mm-hmm.
A lot of people feel guilty from uh, being vulnerable, and we all want to be strong, but there's a limit in what we can do. We are not
Mm-hmm.
super heroes and super powerful, and at some point we need to also accept that there will be limitations, and there might be things you can do to accommodate those limitations. Some might be easy, You might not need someone else to help you with some of those. But for some others, you might need to raise your voice a bit harder if you want to get things done. And you have the right to do that.
We've been raised as a society to believe that we should never show weakness, never ask for help, not take up any space, and just be stoic and get on with it. And I think that keeps people from connecting with themselves at a very human level, and also that vulnerability of connecting with other people and asking for help. There is nothing wrong with asking for help. And so many people suffer needlessly, I think, because of this mentality. And it all goes back to ableism.
Yeah, it is. It is internalized ableism. And
Yep.
if you need something and it can be provided and it needs to be provided for everybody to be able to do things, there's nothing wrong about asking for it.
Hmm.
Like, so
Yeah.
it is a big topic.
Yeah. Yeah. I think that this is really important. You had talked about struggling with this idea of, am I disabled? Right? A lot of people say that. I don't think I'm disabled enough to say that I am, because they may not see how much a condition does impact their daily life.
Yeah. Well, I personally, myself, I do struggle with thinking that I have a disability. For me, it's hard to think of myself as someone disabled.
Hmm. And
Uh,
why is that?
I like to think I like to think that I can do things, and while I struggle at doing them, I still can do most of what I would want. But then where do you draw the line? Where do you start?
Yeah, because ADHD does undeniably impact every day of our lives in how we think, how we process, how we behave, the checks and balances we put into place. And it becomes normalized that this is what we do to cope, but it's there all the time.
It is there. It is there, and I'm definitely equipped differently. I have different tools, and some don't work for what I want them to work, but it is what I got, and I don't know. I've gotten this far in life, and I know some other people might not have gotten so far in life with the same or even worse tools than what I've had.
Hmm. Yeah, and I find that a lot of people, even disability advocates, dance around that word disabled, right? It's like the dirty D word, because it has these connotations and these stigmas attached to it, right? And
It feels like appropriation in my case. Like I've never had to live through things that other people have had to. Like, I've never had to ask for accommodation specifically and explicitly in order for me to get my things done.
yeah, but it doesn't mean that you're not disabled. For example, somebody might say, well, I can't say that this has happened to me like it has happened to somebody else. So it's ableism. You might say, well, I'm not in a wheelchair and I've never not been able to get into my workplace. But yet there are other disabling parts of whatever conditions that we live with. I think people like to try to compare them, but it's also different. There's so much nuance to it.
Yeah, yeah. I think it's also spectrum, and also taking away the shame uh, inside your head and say, I am capable of being ableist. I am
Yeah.
capable of it. And since I'm capable of it, like this thought I'm having potentially can be it. So I won't be, and I'll be open to hearing input from other people. For me, that's what has worked. Hearing you saying things like, "Oh shit," then I am, I have been ableist so far. So I'll be humble. And
And I struggle on the daily with internalized ableism. No matter how much activism and advocacy work I do, we've been inundated since birth with these messages, right?
yeah,
And it's so unconscious. I'm confident that people do not mean to be ableist, and that when you're able to put aside ego and hubris and all that and really consider, wait, why did I think that? What was that based on? And because that's all a part of growing anyway. We're growing up, we are getting older. So what's the point of getting older if we're not getting wiser?
Yeah.
Yeah. So, yeah, I do really believe that people can get there for sure. And conversations like this will help that. I really believe that.
Well, hopefully so. Hopefully so, because it has helped me. We all have prejudice. And like, if I say I don't have any prejudice, then I'm not open to any change in the future.
Yeah, absolutely. Did you just hear my pet monitor go ding? I forgot to unplug it, and it told me that Leo was doing something bad because it has a video camera. In this episode, we talked about a number of themes, like concerning barriers in healthcare caused by bias and stigma, particularly about fatphobic and ableist attitudes in medical settings. As a patient myself, it brings me a whole lot of hope that what you'll do in the future will make real change. And while it's very clear to us that disability discrimination is alive and well, with champions like you working to counter it, the fight is feeling more hopeful by the minute. Thank you so much, Fernand, and see you next time, everybody. On the next episode of Finding Avalon, artist, author, and podcaster Kristen Harrington will be our featured guest. We'll talk about hearing loss, tinnitus, the importance of accessible communities, and her art leadership at Togetherland Art Gallery. Thanks so much for listening, everyone. Don't forget to follow this podcast and share the episode with others you think might enjoy it. Special artist thanks and credit for the unreleased feature song Coal Miner, written by Steve Hoskins, arranged by Naomi Kafka, and performed by Naomi Kafka, Bryn Porter, and Tony Kostelik. Thanks again, everyone. See you soon.